Hello, everyone. My name is Paul Vespa, and I want to thank Teresa and Jean for inviting me to speak today during World Coma Day. My topic will be how to get started using EEG to assess coma patients. These are my disclosures, and the clinical problem that we often face is a critically ill comatose patient with a severe neurological injury, and in whom we've tried to determine what the prognosis is, and our exam is limited in its ability to determine that. The families often have two questions. Can the patient hear me? And what is the prognosis? How will the patient do? What's the outcome going to be? And these two questions can often be sort of transformed into, is the patient conscious? And will there be functional recovery to a meaningful life? How will they end up, and will they get back to a meaningful life? And, which of these questions is sort of more important? And it's sort of a rhetorical question here, but what is the significance of consciousness? What does consciousness really imply for the patient or the family? Oftentimes we place that being aware is vital to a meaningful existence for humans. We associate consciousness with sort of the highest value of functionality. Implications are that if consciousness returns, then there will be normal function and there will be normal good prognosis. And family decisions often hinge on whether the patient is or will be conscious. And what's the significance of prognosis? Well, prognosis is really being, how functional will they be, and will they be functional to a point of a meaningful life and existence? What is their quality of life, and what's the burden of disability based on their outcome? And what's the balance between these things? Prognosis is really a fuller assessment of the degree of functionality, really just beyond being conscious. And really, prognosis is not solely dependent on a return of consciousness. So these are sort of philosophical questions that we deal with. And in terms of evaluating the patient using testing, we really want to sort of get a balance between, are they conscious, but also what is the prognosis? And I think using EEG and other techniques and other data really are getting at a combination of these questions. Some of the methods that we use to assess consciousness, really in the clinical exam, you're familiar with many of these. EEG and various forms of EEG, the raw resting state EEG, quantitative EEG, and task-based EEG. We're going to talk about these things. Evoked potentials, which are a form of EEG in response to a stimulus, including not only the standardized evoked potentials, but also the P300 task. And then functional MRI, which is usually a task-based functional MRI. We're not going to talk much about that in this context of this talk here. Well, EEG has a long history of being used to assess for prognosis of various severe coma types. And there's various forms of EEG, continuous EEG versus short duration. And various things have been used in the resting EEG parameters that can indicate outcomes, and we're going to talk about those. And we're going to talk next, really, in the subsequent slides about quantitative EEGs and evoked potentials and stimulus responsive EEG. This is a very nice graphic from a review paper that looks at EEG findings, which can be helpful in assessing prognosis. And the normal passive resting state background EEG is oftentimes very useful for assessing prognosis. And there are different patterns that can be seen in that resting state. It's called the favorable pattern oftentimes, or the unfavorable pattern. And these have different implications for prognostication. This actually shows a kind of a stepwise approach of how to use these. And second step would often be to give evoked related potentials to sort of see if the patient is interacting with the environment. These are some examples of these patterns of EEG from a very nice review paper. And the benign pattern, or good pattern, if you will, of sort of reactive and continuous background, and then sort of the more what we call malignant patterns or poor outcome patterns of either suppression or electrographic abnormalities such as periodic discharges or suppression burst pattern are a part of the more malignant or poor outcome patterns. And these patterns really have been associated with return of clinical examination in delayed settings, for example, the CRSR or other sorts of outcome measures, and also correlated with, in some cases, imaging parameters of functionality. So they have some basis in outcomes research. We've used continuous EEG and trends, particular trends of EEG, in this case, the percent alpha trend, to correlate with clinical outcome, both in the acute setting, as well as the patterns of these trends over time to look at outcomes. So that's kind of one approach. This is a very nice paper by Elmer and Callaway, just recently came out, which shows a whole variety of different kinds of quantitative EEG parameters that can be used. These are all different sorts of processed EEG or quantitative EEG assessments that have various degrees of influence in terms of prognostication after cardiac arrest. And this is from a large number of patients. And so using the EEG, and especially this quantitative EEG, really can give you added information, although some of these parameters are readily available clinically, like percent alpha, variability, and other quantitative trends, and some things are not. They're sort of more scientific post-processing parameters. This is a very nice paper by Nico Schiff and colleagues looking at both raw EEG as well as quantitative EEG after cardiac arrest. And they use those traditional patterns, the benign and malignant patterns, to look at outcomes. This is the top graph. And they also use the quantitative EEG parameter called compressed spectral array. Compressed spectral array is a segment of EEG that is looked at in terms of the different frequencies, and low frequency and higher frequencies along the x-axis here. And they identify different types of compressed spectral array patterns. And this type 0 pattern really with peak frequencies really out here, the faster frequencies, really has a better association with long-term outcomes than these type 2, type 3 kind of patterns you see to the right of the slide. So another relatively, it's a processed resting state EEG assessment, relatively good help to prognosticate in terms of outcomes. And then we get into stimulus-induced or stimulus-related EEG. That is more on the experimental end of the spectrum here. These are being done in studies. These are not typically done in everyday clinical practice. But this is kind of the paradigm. This is a nice paper that shows the paradigm. You have resting state EEG over here, and then you have stimuli, and stimuli are repeatedly given, and then you look for response of EEG. And this is an experimental paradigm where they're post-processing the data. They're looking at bandwidths. They're looking at the quantitative bandwidths of EEG, and they're looking at what the response of those different bandwidths are to stimulation over time. And you can see that stimulation responsiveness does imply better outcomes, or is associated with better outcomes. And they do pain, sound, and other kinds of stimuli. And if you put them all together, it's a pretty good prognostic indicator on this ROC curve of outcome. So from an experimental perspective, stimulus responsive EEG adds to the information. This is another stimulus responsive EEG paradigm. In this particular paradigm, they used structured stimuli, auditory, unstructured auditory name and pain nociceptive stimulation. And they looked at various segments of EEG, and they did the quantitative analysis of that. And then they looked at the various bandwidths. And what they found is that when they had the delta bandwidth, and they have this what's called phase lag index, PLI, which is really a comparison of different electrode pairs and how they sort of vary with each other. And what they found is that in the delta range, this delta PLI really did associate with outcomes at 3 months based on the CRSR. And so this is, again, an idea that stimulus related EEG can be important in outcomes. Evoked potentials are another form of responsiveness, responsive EEG. This is where various kinds of stimuli are given, and you look at various kinds of responses more in the delayed fashion out to 300, 400, 500 milliseconds. And the P300 is probably the most commonly published one, published ERP out there. And this is a nice paper looking again at cardiac arrest, comatose types of patients, and looking at responsiveness and showing that a responsiveness at the P300 to the patient being told their name is a predictor of awakening. And they get into sort of the scientific possibilities of looking at various sorts of relationships between the different kinds of stimuli and whether or not they can sort of tease out signs of consciousness based on these responses. Again, experimental, interesting, not necessarily ready for prime time. And this is another paper, very interesting, looking at various kinds of stimuli giving rise to P300. And they in this case, they give various kinds of different type of stimulation where they divert attention or they focus attention based on the specific type of task, and they're playing tones in the patient, and they're asking them to sort of count the abnormal tone, and they can look at different kinds of responses at the P300, and then they can sort of separate out these variations and use these for prognostication purposes. So again, very interesting stimulus responsive sort of EEG and evoked potentials. And this is just a number of their comatose patients looking at the various kinds of responses that they get and the variability of these responses across different patients. And then you're familiar with this very famous and wonderful paper by Jan Claassen looking at cortical motor, cognitive motor dissociation. And this is an EEG paper where stimuli are given, instructions are given to the patient, and short segments of EEG are captured. And each of these short segments of EEG are then put through a machine learning paradigm, and then they can look for responses and who is responding and who isn't. And they can divide these responses up into patients that have cognitive motor dissociation and those that don't. And they can look to see who is really responsive. And what they found is that in a comatose population, about 15% or so have this sort of positive response. They have this kind of cognitive motor dissociation. And maybe these things maybe this has implications for outcomes. And so it's very, very fascinating. This is great work, but this is sort of an experimental paradigm with a lot of post-processing of data, a lot of machine learning, kind of proprietary information at this time, and really not ready for prime time at this point. So in summary, EEG really provides reasonable information about prognosis in coma. There's a long history of this, and using it as a routine part of your assessment is, I think, important. EEG can predict those who will return to consciousness. I think there's various variables that can be used for the resting state EEG that have demonstrated this. Reactivity and background pattern is one example, and other examples from quantitative EEG. EEG responsiveness to stimuli can be seen, and this can be seen using a variety of techniques, but the major caveat is that you need advanced capabilities of this EEG, and it's really at the experimental or the observational study phase of medical technology. Stimulus-related EEG can be useful. You have to capture specific EEG segments. Evoked potentials can be derived and also are very important. And the quantitative EEGs of these segments, and then putting that through advanced processing, statistical analysis can give you information. I think covert consciousness is really, this concept of cognitive motor dissociation is really dependent, really still on a lot of advanced scientific technology. AI is one of them, and other sort of signal processing or others. And it's still part of an experimental setting. It's not really ready for use in a clinical setting at this point. But nonetheless, some of the resting state EEG parameters really, I think, can be applied or at least looked for by your clinicians in your group. I thank you for your attention, and I thank again the organizers for inviting me to speak. I look forward to taking your questions.